So good morning, everybody, and thank you, Maureen, and all of you for coming and for thinking and for all the work that you've done. And every year I stand here and think about what we said last year and is there anything new to say? And thankfully, there is always something new to say. So firstly, thank you very much for our patient partners, and it's very much my privilege to welcome them to this meeting, not just as observers, but also as participants. I'm going to talk a little bit about kidney disease in BC and give you another sense for the newcomers here, how we serve our patients, and mostly just highlight what we've done over the last year and what we're going to do going forward. And mostly this is just a way of saying thank you, but also getting us to reflect as a community on what we've accomplished together, because none of this is done by an individual. Picking up on what Maureen said, so the group of population health actually has designed a chronic disease dashboard. And this interactive tool, if you go to it, will actually describe to you the various summary statistics. And from that observatory, according to their data using a number of different coding systems, they can actually describe the crude prevalence rate for the population in BC. And that is, as we all know, growing in British Columbia, and there are various hotspots and increased density depending on where you are. We have 6 health authorities, if you count PHSA and Children's Hospital as one of them, so 5 geographical and 1 virtual, 11 home hemodialysis training stations, 12 PD clinics, 13 hospital dialysis units, 14 CKD clinics, and 28 community dialysis units. And that's how we serve BC. On your left-hand side of the diagram is our famous, very old now, org chart. But nicely, it hasn't changed because the patients remain at the center of this org chart, and they live within their health authority. They don't only have kidney problems, and so we have to recognize that there is a myriad of things that the patients are actually exposed to within a health system. We then have created 5 geographic health authorities where they advocate for and help to deliver that care. And that's all ring-fenced by the various committees of the renal agency that reports up to Provincial Health Services Authority and the Ministry of Health. And this is all run by a number of committees. Some of you I know that, but sometimes where you're in the front trenches, you kind of forget that this is how it all goes. We continue to have and be able to deliver access to care for our chronic kidney disease patients. These are the non-dialysis numbers. We're up to almost 16,000 registered patients. Now, by statistics, you know that there are about 200,000 or 300,000 people with impaired kidney function. This is the people that are registered in our clinics. It doesn't mean that there's an unmet need. It means that there's a larger group from whom we are caring for. We have, over the last 10 years, continued to provide dialysis. Many of us, or maybe not so many as I look around the age in the room, will remember the days where people used to scream and jump up and down about a new dialysis unit required in a certain location. We haven't heard that for a very long time because we're able to deliver care in a nice way. This is the way the provincial committees are structured. I think importantly, we've structured each committee multidisciplinary. So there are soon-to-be patients on every one, but there are on some now, but also nurses, dietitians, social workers, administrators, and physicians representing all health authorities. There are annual work plans, and very much at the core is we're not just doing work for the sake of doing work, but rather making sure that we can evaluate and ensure that what we're doing is good. So we actually are responsible for almost $190 million worth of Ministry of Health money. It's all for direct care, and I'm pleased to tell you that 98% of that budget goes directly to patient care delivery and medications and managing the vendor contracts. The indirect care is actually funded through the Health Authority global budgets. That often creates some tensions, and we're working on how best to manage that. So when patients get hospitalized or have to go to the OR or radiology or get lab services, that's not in our budget. And so that can create some tensions when we're trying to actually have holistic care, and that's our healthcare system design, not the way we've designed it. So we're working on integrating better. Across the continuum, we try and use the best evidence at all time, really listening to people with lived experiences, the patients, the families, the caregivers, and try throughout the spectrum to promote health awareness, primary prevention, and then really try and ensure that there's a very nice, smooth transition, and more about that later, for whatever modality is appropriate for the patient, whether that's conservative care, transplant first, or dialysis. I think that's important that everyone gets that focus. Within the Provincial Health Services Authority, Maureen's portfolio, the clinical policy framework has been developed. And the 4 big buckets are to improve population health, utilize evidence-based clinical prevention, support primary and community care, and delivering quality specialty services. And what we've done is we've taken the things that we do and mapped them to each of those 4 major strategies so that we can make sure that we're aligned. But also, I think you'll agree that those are all laudable aims. And whilst we may not have as much influence on population health status and primary and community care, we all interact with those people. And so there's a way for us to help to co-manage that. So we actually have Kidney Month in March, which is care of the Kidney Foundation of Canada, and World Kidney Day was born from the ISN and IFKF partnership. And this is a multifaceted campaign, and last year there was a fantastic innovative thing about could you lose 80% of something and not know about it, because that's what happens. Kidney disease, as you all know, is a silent disease and you can lose. And this was a very wonderful video where somebody was losing 80% of their clothing and not knowing it. And so if you haven't seen it, please go and look at it. So we leverage these partnerships to make sure that we promote kidney health. And we've been very careful about using the word kidney health, not kidney disease, as a way to make sure that people can hear it and take it on board. So if you were to guess how many people actually watched that video last March in 2019, you might want to guess. I'm not going to make a poll because it takes too long and it's still too early for you guys, but it's over 130,000 people actually viewed the video, which means from a population awareness perspective, if you go back to that first column, we're actually getting somewhere different. So the social media impressions were almost 1 million people. The video views were 133. And there was an app that actually allows you to assess your kidney health that was downloaded by about 6,000 people, which is pretty impressive because that's actually an increase from last year. So it's not same old, it's that we're reaching more and more. And this is thanks to a fantastic communication team and everyone else. You may not remember this, but there was a time before EGFR, and EGFR was born in 2000-ish and then was actually taken up into the lab. You also may not know that the first laboratory system in North America was in British Columbia, where we actually standardized the EGFR reporting, simplified the test results, and combined it with the general practitioner guideline for primary care, which is really important. We continue to collaborate with the Kidney Foundation for screening, and you'll hear more tomorrow about the program within CanSolve, the Kidney Check screening program in 10 Indigenous communities around the province to try and promote kidney health awareness, but also to identify people earlier. We have a number of primary care linkages and strategies, and I'm not going to read them all out here, but we do link, therefore, with primary care, have education, offer lunch and learn programs, telehealth, and residential care partnerships, all in an attempt to take health and wellness into the community. When we look at what we've accomplished, we certainly have earlier diagnosis and the earliest diagnosis in any of the provinces across Canada. There was a time where dialysis was growing 16% on base, and that was why people were screaming about dialysis needs. And now it's down to 1% to 3% depending on the year, and maybe that's attributable to multiple interventions that we've done. We have reduced consultation times in nephrology, although they fluctuate. And really importantly, we have in this province amazing access to all medications for kidney diseases, rare and otherwise, seamlessly, and in the last 5 years, very seamlessly with respect to the glomerular nephritis diseases and polycystic kidney disease. Our mandate, if we map it to the clinical policy framework, I think is there. We do drive quality through the use of quality standards. We optimize delivery, and we enhance an integrated care system. And we have the highest survival rate in the country. Now, the little secret is that BC has the highest survival rate in the country because there's something about living in BC that's really good for you. But our kidney patients and transplant patients also have great survival. We also have the highest rates of people on independent dialysis in the country, which is something we're really proud of, and the most extensive financial support for medications, which is also impressive. We have a Transplant First partnership with BC Transplant, Kidney Foundation of Canada, and all the health authorities to try and promote kidney transplantation as, for those eligible, as the first modality, not having to go to dialysis first. We have a number of staff education sessions. This is all put on in the context of your daily work, but in a volunteer capacity, but because we all understand what we're doing and why we're doing it in real time. We have amazing transition guides. If you haven't seen them, please go to the website and download them. It's patient-facing that actually helps patients to understand where they're going as they transition from kidney care through dialysis or transplantation or conservative care, and what to expect at different points. We, as healthcare providers, sometimes forget that we know where you're going, but we don't always are as good as we would like to be at letting people know where they're going along the way. And this has been very valuable and developed with patients based on their needs, not what we perceive their needs to be. And there are different new modality choice education tools, and the Pkd Initiative. We have the first ever in any jurisdiction a Pkd network, much like our GN network, with an advisory committee, education sessions, and a best practices guidance with tools for patients and protocols being developed. The PD committee has done a lot of work, and there are some new automated machines that are provincially rolling out this fall. We have a number of different procedures and cross-program input and participation, and we have a patient improvement project with our vendor to try and make sure that that people actually get the care they need when they need it, but also the services are more tailored to them. The Home Hemo Committee also has been doing these transition guides. There are some new bloodlines, which are an improvement over the previous, and we had an amazing advocacy to municipalities to waive the garbage fees. Now, this might not mean a lot to many of you, but if you have to pay extra to have your garbage taken away because you're a home patient, that's on you, and that's not fair. So with the Kidney Foundation and the various health authorities, we actually had a very strong advocacy, and I believe the last set of emails I read describes the fact that they will be waived, and that's really a fantastic kudos to the people that put that together. TB screening in all new dialysis patients is something that we've been doing and demonstrating, have written a paper describing not just the risk that people have of TB when they're on dialysis, but the value and those lives saved or infections not had because of the IGRA screening and treatment program that's being submitted for publication. And there's a the business case was approved, and we're working with Maureen and others to also ensure that that includes all new kidney failure patients, including those who require a transplant. And that's how we're going to couch it so that it's not just dialysis patients. We have a huge amount of infection control guidelines, and now people can travel within BC according to a very standardized set of patient guidelines for travel, and our acuity scale is measured every 6 months. The Palliative Care Committee has also been working in an amazing way, led by Sarah Thomas and Gayleen Hargrove, an integrated project that helps to increase clinical and clinician engagement in advanced care planning. There's a workshop later this afternoon for serious illness conversation, and so far, over 700 of you in the renal community have actually been involved in that course, which means that we're better at talking to patients about the stuff that matters and actually hearing and being able to execute on this. And so again, this is a part of the Palliative Care Program of BC, and shout out to they've shouted us out as actually being a model of the way that we've actually implemented this, which I think is amazing, and true knowledge translation in real time. We have the first ever GN Atlas. Glomerular nephritis is a rare disease, but actually the fourth most common reason that people go on to dialysis. It affects children and adults. And importantly, we've got an amazing network that actually has this atlas, a formulary, pre-printed orders, protocols, and ongoing publications. Fantastic papers in both JAMA and Kidney International, which have very high impact factors, both of which got editorials, which means that it wasn't just that we wrote a paper and it got accepted, but rather that the editors thought it was worthy to then highlight it to the readership. And that, I think, is the ultimate compliment for the integrity of the science and the value of the work that's being done. We have, with Helen Chu's amazing work and tireless efforts, developed a patient and family engagement framework, which will be rolled out over the next year and is a follow-up to the patient experience survey that we've been doing every 3 years. And I think that is, again, our commitment to integrating patients into everything that we do. And as a component of our mandate, innovation and research is what we're doing, and we've got multiple publications. This is just a screenshot of our website. If you go and you click on any year, you'll see any publication done by people in the renal community. That includes transplantation, basic science, translational science, nurses, physiotherapists, pharmacists, whatever papers have been written, because you're part of the renal community. And I think it's pretty important. We're starting to embark on province-wide clinical trials, which is something near and dear to my heart, because I think every patient should have the opportunity to, and we should have the opportunity as a renal community to contribute to that knowledge, and I think that's important. And we're working on a more streamlined ethics and oversight and ability to actually conduct those clinical trials. PROMISE is our integrated provincial clinical information system, and it matters for a whole bunch of reasons, but the most important thing is that it's a critical link in the life support for all kidney patients and solid organ transplantation patients. It actually has a huge investment of person time and dollar time. And this is just a schematic to just give you a sense. PROMISE doesn't just sit on your desktop and tell you about the patients. We actually feed the information to the Canadian Transplant Registry. We actually use it for CORE, the Ministry of Health, for evaluating things, and it interfaces in a number of different ways with all the different health authorities and various EMRs, and it's the way that we actually have seamless care. And parenthetically, with the advent of newer information systems like Cerner, one of the challenges is how you maintain the integrity of that provincial database in the context of ongoing change. It's a provincial database for all the lab results, all the biopsy results, all the immunology, everything. So how do we make sure that maintains in the center of things? So how many labs were downloaded into PROMISE over the past year? You can think that it's probably the very high number. Almost 1 million lab tests seamlessly in real time, day on day. So when you open the patient's record, you can actually see their blood work. Importantly, about 600 people use PROMISE every day. And so we have a number of different reports that we've run, a number of different outputs of PROMISE, not all PROMISE per se, but through our analytic team and the communications team, but important to realize that it's really the backbone. And you'll remember when we first started the Renal Agency, we said we had to have information that was by us, for us, so that we could inform our care and show that we were doing the right things, and that's the genesis of it. There's the fourth release, and we've got some ongoing migration and other things, but important, visit the PROMISE booth and talk to people, and it continues to grow. And is it the perfect system? No, but it is the system that keeps us together as a province and seamlessly integrates everything. We remain accountable to the people that we care for, the health authorities, the Ministry of Health, and everyone else. And so we have all of these different ways that we report, as well as to our working groups and modality committees, so they know that what they're doing is working. And then we also support research. And that's done with a pretty small, nimble team, often overworked, led by Ognjenka and Lee and others. And I think it's important they be recognized for the amount of understanding that they now have of kidney disease, so that they can actually produce the information that you need and not just answer the question that you think you need answered. So we've had a number of regional innovations and multiple quality improvement initiatives, and I think that's important. That's how we use our extra dollars that we negotiate through our value adds, and you please see the posters to see the outputs of some of those things. This is how we are nimble and demonstrate that what we're doing is good or that it doesn't work, and therefore you can not keep doing it. Please look at all of our online resources, website, YouTube, social media, and our e-newsletter. These are there to inform us about what we are doing. This is all about a togetherness thing, and I think whilst I may not be the biggest user of YouTube or Twitter, the fact is that this is how people hear about what other people are doing and, importantly, keep abreast of everything. So we actually... Are we doing this poll? Yes. So how long have you actually been involved in renal or kidney transplant care? I just want to get a sense in this room of over 500 people, how long you've actually been in this community. Use your app. So to the newcomers, less than 2 years, welcome. There's lots to do, and there's lots that you can do. For those of you that have been here for 10 years, which is almost half of you, I think it's a demonstration that once you're in the renal family, you don't leave. We already knew that for a long time, but people seem to stay for a long time, which is great and probably a testimony to your commitment to the patients. And then those of you that are here for 10 to 20 years, the fact that you're still here is also a great sign. And so thank you for staying and continuing to commit to all the things that we do together. So the other thing that we do to sustain our community is we actually fund and co-manage with University of British Columbia various supported fellowships. And so the clinical fellowships that we're supporting this year are for Isa Wahid, Susie Hewitt, Shane Donnellan, Catherine Lamour, and Heather Gunning. Heather is our first GN fellow. We've never had a GN fellow before. ANT stands for Advanced Nephrology Trainee. We're the official training site for New Zealand and Australia extended nephrology program, and so that's where that name comes from, but this also is open to people in Canada. Our postdoctoral clinical research fellowship, Dr. Mark Canny is doing that, and Peter Burks is doing an administrative fellowship with the Renal Agency, learning how to use and ask data and how we actually move that forward in answering important clinical questions. At the same time, there are core training nephrology fellows, pediatric fellows, and transplant fellows, and I've listed them all here. I don't have time to shout out all of their names, but importantly, these are people committed to making sure that we have a sustainable renal community as some of us age and can't keep doing what we've always done. And that's before I've actually shouted out the nurses, dietitians, pharmacists, and social workers who are also in training in each of the various health authorities and are exposed to nephrology and often then come back to the nephrology community because their experience was so great. And so that's another way that we sustain it. So I'm going to end there, a tiny little bit over time, I apologize, but really to thank all of you for your energy and commitment to people that are living with kidney disease and for those that are trying to keep their kidney health. We can quantify the number of people who are on the committees to be around 300 or more, but importantly, everybody contributes in very different ways, but very important ways to the kidney health of this province. And as I always say every year, we don't have an us and them culture. BC Renal is us, and we work together to actually make a difference. So thank you very much for all of your time and commitment.